neurosurgery at Hoag Hospital, as well as a professor of neuroanatomy at 3 different universities. I'm also on the Medtronic design team for the next generation of Stealth, so helping along with 9 other surgeons design the next generation of navigation systems, which we start doing 5 years in advance. So we're working on that now. I'm also the neuroanatomy editor for Netter's Anatomy, which I'm sure you've heard of. Just a bit of common ground between us. My family is actually from Kfar Ouna, Lebanon, which is only 30 miles from here, just across the border from where we are now concerned. And emigrated to the US when my dad was just a baby in 1948. Of course, 1948, we share that in common as well as the year of birth of this nation. So although we have many differences, I think we have more in common than we have difference between us, and these are my Israeli brothers who I'm grateful that have been hosting me while I've been here, and I could not feel more welcomed or more safe since I've been here. It's been an amazing time so far, and I thank you to all of you for having me. One thing that I love about this nation is the innovative aspect of everyone. This was last year at APAC. We presented surgical theater, and just before us speaking on stage was at the time our Vice President Mike Pence. So the stage was 13 or 15,000 people watching and showing how Israeli technology, which was designed for war, is now being used to save lives across the world. And this is something we're very proud of, that this was originally technology that was designed for space travel and then for war, and now we're using it to save lives. So with that in mind, we're going to be talking about some problems today that exist in neurosurgery and how Israeli innovation is being used to solve those problems. So just a bit of an overview. The first problem is that traditional systems force surgeons to visualize images through the eyes of a radiologist. We're going to go through these one by one. The second is that there's no way to practice an operation on a specific patient prior to surgery. We call it the practice of medicine because each time we practice, we're getting better, except sometimes there are consequences. Number 3, residents have fewer and fewer opportunities moving forward to have hands-on learning. Patients do not understand DICOM images. And most importantly, traditional navigation approaches require the surgeons to divert our attention away from the surgical field in order to figure out where we are or confirm where we are, and then look back. It's called context switching, and this, by the nature of the way navigation works currently, is required, and that's a problem. So just a bit of a historical perspective, many of you may know 1885 was the first case of cerebral tumor in the modern era. It was a 25-year-old male in England that had paralysis of the left arm and hand. Based entirely on animal models with no imaging capabilities at all, they realized that he had a tumor in the right central sulcus, and they even knew in the mid-portion of the central sulcus. And using what we now know as Taylor-Houghton lines, they were able to accurately localize the tumor, make a craniotomy with no anesthesia or antiseptic technique, and successfully remove the tumor. This is an illustration of the brain afterwards. And the patient survived the operation. Now, unfortunately, he ended up dying about 4 weeks later from an infection. Again, because this is not only before antibiotics, but before even antiseptic technique. So, however, it was the first time in human history that it was known that we were able to successfully intervene on the brain, and they presumed with better perioperative and postoperative care that we would ultimately be able to do it with better long-term outcomes. Fast forward 80 years, the MRI machine was 1973, Paul Laberder and Peter Mansfield. Of course, it took until 2003 for them to win the Nobel Prize for the MRI, but this is now the modern era, at least tongue-in-cheek modern era, of the way we image patients. But you can see, this is the way we've all become accustomed to looking at MRIs because that's the way the radiologists give them to us. Navigation was also one of the major leaps forward in neurosurgery. Based on navigation technology for sailors from the 18th century, it was 1987 the first navigation technology was introduced. And it took about 15 years for it to become standard of care in neurosurgery because we surgeons have big egos and we are slow to adopt new technologies, even when it's intuitively there's progressively more evidence that it helps make things better. We're just slow to adopt new things because we don't believe that we can do any better than we're already doing. So we've got all these innovations, or some of these innovations, and yet in 2015, this is a patient that we had operated on while I was in residency, and I call this maximally invasive neurosurgery with this huge across the top of the forehead incision, and then we remove the whole frontal bones, and he gets an infection. We have to remove it, and we can do better. So that's what advanced technologies are enabling us to do. So this is one of the things I'm involved in, is the development of advanced technologies to allow for increasingly minimally invasive approaches, not only for skull-based surgery, but for all types of brain tumor surgery, aneurysm surgery, and beyond. So on to the problems. Problem statement number one. The traditional systems force surgeons to visualize images through a radiologist's point of view. If you think about that for a second, this is the way we are used to viewing MRIs. There's a video there. Is that playing? Just click here. Kind of cross sections, black and white. And although we think we're pretty good at it as neurosurgeons, I guarantee if we look through this and I ask you, okay, try to recall the passage or the course of the en passage vessels that are going through this tumor, no matter how many times you scroll through it, you're not going to be able to close your eyes and visualize the vessels passing through the tumor. Similarly, imagine the course of the basal vein of Rosenthal in a patient with a trigeminal schwannoma. Are you able to close your eyes and imagine where that's going to be? Imagine the relationship between the vessel and the superior cerebellar artery? At least most surgeons, even though we think we are great at this, are not very good at it at all. And when we test it, like Al Roton used to do, one of the great neuroanatomists, neurosurgeons that taught this see-through anatomy, when you test it, we're not very good at it at all. So that's because we are forced to look at these images through a radiologist's point of view. Even if you add on tractography, trying to reconstruct in the mind's eye normal anatomy for tractography, we're pretty good at. When it comes to abnormal anatomy, there's not a template for it. It's each individual patient. Sometimes it's displaced anteriorly and superiorly. Other times it's displaced posteriorly and inferiorly. And you add on to that the course of the vessels, the position of the motor cortex, the position of the arcuate fasciculus. And it becomes an increasingly complex model which you have to build in your mind based on these two-dimensional images. Now you take the way we should be seeing it. This is surgeon's eye view. This is the way we see the world. With all of these structures in it together, developing what Al Roton was trying to train into us, the computers are now able to feed us the information so we have it available, so that when I'm studying this patient's anatomy prior to the case, these are the types of images we're looking at, or at least should be looking at in the modern era, as we get increasingly close to that three-dimensional see-through ability to perform surgery. So if we compare radiologist's view, where I can see, okay, I have to scroll through and flip through and look through multiple sequences to be able to see what I really need to see, and whereas here, a single view, which shows me the position of the vein of Traulard, which shows me that the corticospinal tracts are, in this case, posteriorly displaced, shows me where the hand nobule is, shows me where the arm motor cortex is. All of these things in a single view, which then I can take this and imprint in my mind in order to prepare myself for surgery. Let's look at another example. This is from Mount Sinai University Hospital, Dr. Betterson in New York City. So we've all seen two-dimensional angiograms, even 3D angiograms, where we kind of look at it and you then have to match that with the MRI and try to build a model in your mind. Instead, when we're using 4D angiography, where you're able to segment out and identify in different planes and look at it from different points of view, where are the arteries, where are the veins, where is the nidus of the AVM itself? As we look through these images, we can see the transition between artery to nidus to vein, and it gives us a better three-dimensional understanding, or surgeon's eye view, in order to better prepare us for surgery. That's one problem. Problem statement number two. There is no way to practice an operation on a specific patient prior to surgery. You may have done a pteriomal craniotomy hundreds or even thousands of times, but each patient's anatomy is different. Each tumor is different. Sure, there are known anatomical variations, but it's impossible to memorize all of them. And then when you add pathology in, it distorts the anatomy so that trying to remember your medical school or residency version of anatomy with a distorted version of it, of this patient's anatomy on top, you can't practice the operation. You just go in, you study the images, you go in and you do the best you can. There is no way to practice an operation until virtual reality. Chris Ahmad, who's the orthopedic surgeon for the New York Yankees, talks about the differences between and similarities between elite athletes and elite musicians and elite surgeons. And what he says is there are many, many similarities in the way we train and prepare and the number of hours we put in. But the major difference is that athletes and musicians, when they become professionals, continue to practice. Michael Jordan was practicing free throws 5 days a week, even when he had 6 world championship rings. This is the level of practice that professional athletes put in. Same thing with musicians. If you're playing in world-famous orchestra, they're still practicing. As surgeons, we do not have the ability, at least did not have the ability, to practice until the creation of virtual reality. Fighter pilots, we would not consider letting a fighter pilot go up in an F-18 or an F-16 without hundreds and hundreds and hundreds of hours in a simulator where there's no risk. If he crashes in the simulator, he just loads it up and does it again until he gets it right. So the idea is that practice may not make us perfect, but it's what makes us better. And practicing without consequences is what virtual reality allows us to do. So we can, and this has been studied, there's plenty of data on this for the last 15 years and the effects of using virtual reality for surgical rehearsal and planning. This is a study going back to 2008, where 23% of the time, the virtual reality led to a change in the surgical plan. In this one study, 88% of the time, VR led to a good or very good improvement in the craniotomy planning. Let's look at an example of that. So one of my favorite operations is the eyebrow craniotomy, supraorbital. This is a patient, young male, that was losing vision in his right eye. Based on the DICOM images, I had planned an eyebrow craniotomy, except when I did the 3D fly-through, when I did the VR rehearsal, I realized that there's a small segment of tumor, a little tongue of tumor right down behind the supraorbital fissure, right there, that I was not going to be able to get at through the supraorbital. So rather than making that mistake on the patient, I made it in the virtual reality model. I practiced, and I said, you know what, let's try a mini terional. Same size opening, a little bit bigger incision, about a silver dollar size craniotomy. And from this view, from plan number 2, I was able to get direct access to the tumor. We resected it, patient went home the next day, and his vision was completely restored. Now, I might have made a mistake in that patient and tried to, once I realized during surgery, tried to reach over the sphenoid wing and get out that tumor, or I could have left tumor behind and this is a young man, he would have needed radiation. Instead, the mistake that I made in virtual reality allowed me to correct it and not make that mistake on the patient. This has been studied again, the study I showed before, another study from Mount Sinai University showing very similar data. And this has been done at Stanford as well. 24 to 25% of the time, using virtual reality to rehearse the surgery leads to a change in the surgical plan. If you think about that, almost a quarter of the time, you might be doing a suboptimal or incorrect approach. And the reason for that is what it allows is for us to predict and experience the operation before we get in there. It allows us to experience line of sight. And what that progressively allows is for us to make not template or cookie cutter craniotomies, but the precise location of the best craniotomy for this particular patient. Problem statement number 3, residents have fewer opportunities for hands-on learning. This is an obvious one for many reasons. For example, in the United States, the number of hours they're allowed to work is limited. I'm not sure if it's the same here. But in addition to that, the tolerance to residents making mistakes, which you have to do in order to learn, is decreased. There's increasing oversight. It used to be that in the nighttime, the residents would just do the cases on their own. Even when I trained, the faculty would say, yeah, call me if you need me, I'll come in if you need. It's no longer the case anymore because of the medical legal system. So the hands-on learning opportunities for residents are decreased. Okay, one solution for this is cadaver labs, right? We've all done cadaver labs. We go once or twice a year and we do skull-based drilling. The problem with cadavers, they don't have pathology. They don't have the clinoidal meningioma that we can figure out if we're able to get the best line of sight on. We can do the approach on a cadaver and then, yeah, I can see the optic nerve and the oculomotor triangle, but they don't have pathology. So it's not a good way to rehearse. They're not patient-specific. You can only do it once or twice. We don't have cadaver labs that we can use every week and practice the operation. And again, back to this idea that practicing something again and again without consequences is beneficial to us. The more we practice, the better we get at it. It's not specific to the individual case. Again, variance in anatomy exist to the nth degree, and only by practicing on this specific patient? Are we afforded the ability to make mistakes, correct it, do it again? It's inconvenient, setting up the cadaver labs, they often don't have them in the hospital, or they don't have the equipment that you can do it again and again. It's expensive. Each head you go through, you only get 2 sides. You can use it for maybe 3 or 4 total approaches per head, and then you have to replace it. And you can't repeat the same approach on the same head. If I want to do the same craniotomy 5 times, I need 5 different heads, or at least 5 different sides in order to practice it. So by comparison, virtual reality, you can repeat infinitely. It's patient-specific. It allows the residents to practice the operation before getting in. So if I am training residents, which I don't do, but I would love to get back to that someday. If I'm training residents, if they say, okay, I'm ready, put me in, I'm ready to do the operation, show me that you can do it safely in the virtual reality. Show me you know where to place the craniotomy. Show me that you know what structure is going to come next once you split the sylvian fissure. Show me, point out to me where the danger points are, where the critical structures are going to be in situ, in the virtual reality model, and then you're ready to get your hands wet. This is now how it's being done increasingly at hospitals throughout the United States. This is the resident training lab at Stanford, Dr. Gary Steinberg, who many of you may know in the center there. And before complicated cases, we have Dr. Steinberg and ability for 4 residents to be able to walk through and rehearse the case and discuss it, just like coaches do with their players prior to getting into a game, or just like the conductor does with an orchestra prior to a concert. They rehearse beforehand. The less experience you have, the more the residents need to rehearse and practice in order to get better and better at it. Statement number 4, patients do not understand DICOM imaging. Many physicians don't understand DICOM imaging. We as surgeons do, we've been trained to do it, but if you look at kind of the standard, to me, this looks like a Rorschach blot. Maybe it's a bat, or maybe it's 2 witches kissing, but it certainly doesn't look like anything to a patient. Whereas my 8-year-old daughter understands the green thing is bad, right? If I've got that, you're going to take it out, right, Dada? So it's intuitively obvious to patients. Now, we are moving away from this era of paternalistic medicine, where the doctor just says something and the patient does it, and towards an era where we want our patients to better understand the treatment plan. This is something we studied. We published on this last year. What impact does standard DICOM imaging have versus use of virtual reality in the consultation? And what we found is, as compared to standard DICOM imaging, 360 virtual reality patient engagement or consultations leads to 80% of patients rating their level of understanding of their planned brain surgery as a 10 out of 10. You can see kind of a little bit skewed bell curve before with just DICOM imaging, and 9 or 10 out of 10. Nobody had below an 8 once they had the DICOM imaging. Again, this is taking lay people and explaining to them their planned brain surgery. It speaks to how immersive and how intuitive the 360 models are, and how helping patients be better informed and prepare for surgery has actually also been studied. They studied this at Tufts. Not only does it improve their level of understanding, but it improves patient-reported outcomes. The patients themselves feel that they do better when they're better prepared for the operation, including the risk. Taking a bit of risk myself, this technology has not only helped me to better engage patients, it's also saved me from lawsuits. 1/3 of lawsuits in the United States, medical malpractice lawsuits, are because of claimed failure of informed consent. When the jury looks at a 360 model and they say, yeah, you could not claim that you didn't understand that the tumor was involving the optic nerve, because the optic nerve is disrupted. You see tumor, and then you don't see any nerve anymore. So when this gets to the malpractice system in the United States, it protects the physicians, because it allows them to say, listen, there's no way you didn't understand. If the 12 people on the jury understand, you understood this, and the cases are dismissed. And this has been actually picked up even by the malpractice companies now as a way to help doctors defend against these lawsuits. But more importantly, the point of that is that it's helping patients feel more prepared for surgery. So helping doctors be more prepared for surgery, helping residents learn and train better, helping patients be more prepared for surgery, all accomplished by advanced visualization. Finally, problem statement number 5. Traditional navigation requires the surgeon to divert their attention away from the operative field. Now, I don't know about you guys, but for me, I get frustrated when I have to look away from the operative field because the scrub tech hands me the probe upside down. Each time you have to do that, like, don't you know how to hand me the instrument? Because it requires context switching. You have to look away, you take your focus away from the surgical field, then you have to look back. Each time you do that, it interrupts your flow. We all know the concept of flow, right? I mean, sometimes you're in an operation dissecting a clinoidal meningioma or an acoustic or dissecting around an aneurysm, and it just feels right. It feels nice. It feels beautiful. That's when the operation is going well. Of course, if you're starting to look at the navigation and having to look away, it takes away from the flow. Not only do we have to divert our attention from the microscope, we also have to look at the images, look at the DICOM, reconstruct the model from the DICOM back into a 3D model, and then apply that in our head back onto the surgical field in front of us. It seems like a simple task, or seems like something we do very well. It, again, is not something we do very well, to take that two-dimensional point and apply it to exactly where it is in the three-dimensional field in front of us. So this is where operative navigation stands in 2020. In my mind, it's outdated. Where I think, and as part of the Stealth design team, is what we're looking to building into the next generation, is augmented reality with heads-up display to allow the surgeons to maintain focus on the surgical field. Let's show an example of that. So what it is allowing the surgeons to see what they cannot see. This is a clinoidal meningioma. If you look at it even under the microscope very closely, I guess you can see that, this is the optic nerve right here, but it does look similar. Maybe this is it here, maybe it's here. And the carotid artery, you can kind of see, the shadow of it here. When we have augmented reality, we're able to see where these structures are. It gives us that alroton, that see-through anatomy, which we can all develop in cadaver models, but having see-through anatomy of the course of an optic nerve through the tumor, and the course of the carotid artery through the tumor, augmented reality certainly helps to allow us to visualize these things, and again, prevent us from this back and forth context switching of looking away from the stealth. I've got a couple of examples of cases. This is preoperative rehearsal. So again, rather than looking at the DICOMs, I put on a VR headset and I am doing a virtual reality rehearsal. I'm making the craniotomy specifically to expose the precentral sulcus. Then I select the craniotomy. It can be selected as a polygon and removed from the field, so I can use that as a template. I'm selecting an approach that's going to be between these two cortical veins. This is the approach I choose to do in the preoperative rehearsal. Once I've rehearsed, now I have on the left side of the field, intraoperative augmented reality. I've got the template for my craniotomy, including where those cortical veins are. Now I make the same craniotomy, about a 4x4 centimeter craniotomy. Again, here's the virtual representation of what we're looking at. And throughout the case, I'm turning the AR off and on to give me that heads-up display. Here's the dural opening. This is like hyperspeed, like 10x. And what we're doing here, you can see there was a little bit of adjustment we had to make in the role of the augmented reality. Once I do that, I align these cortical veins on the surface. I know that the rest of the structures are accurate. So what I do is take a known anatomical structure, match it up to the AR. Now here we're using the phase reversal technique to identify that this is indeed the motor strip. We've got motor cortex, 3 different points on the motor cortex mapped out, Broca's area down here in the blue. And again, throughout the course of the operation, continually bringing the AR in and out so I know where the tumor borders are. As it shifts, we can use the augmented reality to adjust for that because I know where those two veins are. So if I have, for example, Z shift down towards the floor, and I take those two veins and I roll it in the Z direction, I've then realigned to partially compensate for brain shift. Of course, this is the corticospinal tract at the depth of the resection once the tumor has been completely removed. And this is the postoperative fly-through showing where our intrasulcal approach to that premotor cortex, showing the corticospinal tract and arcuate intact. This patient actually presented with a bit of a speech deficit as well as some right-sided hemiparesis, just mild, ended up 3 days post-operatively totally normal recovery. So putting those things together, here's another example. This one's a bit of a different case. So this is a patient with left atrial meningioma. You can see the position of the pretty typical for left atrial meningioma. Again, the ability to look at these 360 images and then take different layers in, being able to visualize the corticospinal tract, the optic radiations, rather than going through the DICOMs to be able to visualize it from the surgeon's eye view. Now I introduce a tool. I'm doing this through the BrainPath system, the port. So I choose the sulcus that I'm going to introduce that into based on where the corticospinal and optic radiations are. So I'm rehearsing in VR and imprinting these images into my mind as to what it's going to look like. Now, here's the intraoperative augmented reality. I make sure that the overlay is accurate based on the sulcus that I chose that I planned based on the VR rehearsal. I've got my planned trajectory here on the right. After we've split the sulcus, I'm now introducing the BrainPath down along the planned trajectory. You can see I'm actually a little bit off the trajectory there. Docking down onto the tumor. And now here's our view. You can start to see the surface of the tumor there as we bring the augmented reality in and out. Many of us have been in these cases where we're doing a meningioma resection, you're like, yeah, I think I got 50, 60% of it out, and you end up, no, I actually only had 10% of it out when you think that. It's hard to sometimes get a scale of where you are. One of the things that AR is great at is kind of giving us the shell of where the tumor should be, at least, before BrainChip. And with this kind of thing, BrainChip isn't nearly as much of an issue. I don't use any mannitol or hyperventilation for these BrainPath cases. So when we dock the port down onto the tumor, generally the anatomy stays pretty much where it should be throughout the rest of the case. Again, the AR is not on the whole time. I'm bringing it in and out as I dissect around the tumor to remind myself of where the critical structures are without having to context switch back and forth between the DICOM images and the microscopic image in front of us. So we're always seeing that the live surgical image on the right and the virtual representation of this, which this part is on a screen. Of course, now we've removed the tumor completely, and this is now after complete resection, showing kind of where the tumor was or the shadow of it. And as we scroll down with the microscope, as we focus down, we're done with the resection. We take out the tube. Here's our craniotomy, just as planned. This was the plan was in blue, and the actual, see the craniotomy there, and then a complete resection with postoperative DTI demonstrating intact optic radiations and complete resection of the tumor. So, one more case. I'm not going to show a video for this one, and I don't think we have time, but this is the patient with a large dominant hemisphere glioblastoma. In this case, when I first looked at the DICOMs, I said, this is mostly frontal lobe, but some parietal. I was thinking I was going to go through the precentral sulcus like I did on the other one, but when I brought the DTI into the 3D model, I realized the corticospinal tract is displaced anteriorly. So in this case, I chose the postcentral sulcus as my entry point, and based on the virtual reality planning and then intraoperative augmented reality, was able to do the operation through similar size craniotomy, about a 4 by 4 centimeter craniotomy, and this is gross total resection of that. Again, postoperatively showing the corticospinal fibers intact, and patient on postoperative day 3 with still mild sensory deficit, but normal speech recovered after only 3 days from their initial presentation with expressive aphasia. So, just in summary, advanced visualization technologies in neurosurgery. Number 1, allows viewing of images not from the radiologist's point of view, but from the surgeon's point of view, the way that we see it at surgery. Number 2, enables preoperative rehearsal to experience this specific case in this specific patient's anatomy. Number 3, affords residents better opportunities to practice again and again and make mistakes without consequences. Number 4, allows patients or enhances patients' understanding of their condition and the surgical plan. And finally, it presents an accurate overlay of patient-specific images within the surgeon's field of view, allowing us, the surgeons, to maintain focus, preventing us from having to context switch, and allowing us to focus on the task at hand. So the evolution of our field over the last 125 or 130 years has been from Taylor-Houghton lines with no imaging at all, to symptoms-based localization, to MRI based on DICOMs, to now in 2021, this is the way that I want to be seeing my images in order to prepare and plan and perform surgery. Quite a difference in quite a short amount of time, and this, in my mind, will be the standard of care in neurosurgery over the next 5 years. And just to finish, this is my little girl, and every time she's my amazing amazing part of my life. And I love this quote that we must hope to give our children a sense of what it is to be a loyal friend, a loving parent, and a citizen who leaves his home, his neighborhood, this world better than they found it. And this is why I decided to come here still today, in spite of what's going on, because we in medicine